Good morning, Chairman and every professor. I'm Jiahui Chen from West China Hospital, and today my topic is about the association between dietary inflammatory index and the pelvic floor disorder among adult women. As is known to us, pelvic floor disorder is a series of bothersome conditions attributed to the weakness of the pelvic musculature and or connective tissue, including urinary incontinence, fecal incontinence, and pelvic organ prolapse, and so on. It can substantially affect women's quality of life. And pelvic floor disorder has many reported risk factors such as BMI, age, and delivery mode, and so on. However, study on its association with dietary pattern is limited, and dietary inflammatory index is a comprehensive indicator designed based on 45 parameters to measure the inflammatory potential of an individual's overall diet. And a higher DII score indicates a pro-inflammatory diet, and it is associated with a higher level of inflammatory marker in the body, such as TNF-alpha, C-response protein. And we used data from Enhance National Health and Nutrition Examination Survey. It is a national cross-section survey performed by CDC, and in our study, non-pregnant women aged more than 20 years old with complete information on pelvic floor function and 24-hour dietary report were included. And for assessment of pelvic floor disorder, it was based on several questionnaires. Briefly, urinary incontinence was determined by the frequency and amount of urinary leakage, and the fecal incontinence was determined by the frequency of the stool leakage, and the POP was determined by experiencing something falling out from vagina. And the woman with at least one of them was recognized to have the pelvic floor disorder. To calculate the DRI, we used the method proposed by Shavipa. Briefly, as shown in this table, each food has its own inflammatory effect score, and the food-specific DRI score was calculated by multiplying its center percentile and its inflammatory effect score, and the total DRI score was the sum of each food-specific DRI score. Finally, we use multi-variable logistic analysis to explore association between DII and the risk of pelvic floor disorder, and the RCS function to explore the exposure-response relationship between them. In this study, we included a total of 6,406 women with the DII ranging from -5.2 to 4.83. The prevalence of the pelvic floor disorder was 23.9% with 16.7% of urinary incontinence and 9.2% of fecal incontinence and 2.8% of POP. And showing this table, we found that with 1 unit increment of DII, the risk of a pelvic floor disorder will increase about 8%, and compared with the women in the lowest DII group, such risk would raise about 56% in pelvic floor disorder, and 34% in urinary incontinence, and 95% in fecal incontinence among those in the highest group. Furtherly, when stratified by BMI, we found such association only found in the obese women. Among them, with 1 unit increment of DII, the risk of a pelvic floor disorder would increase about 9%. As for the exposure-response relationship between them through RCS function, we found all p-values for non-linearity was more than 0.05, which means the exposure-response relationship between them was linear. In summary, through this study, we found that nearly 1 in 4 of adult non-pregnant women complained of one or more pelvic floor disorder, and urinary incontinence was the most common of them. And the women with a pro-inflammatory dietary pattern has a significantly linearly increased risk of pelvic floor disorder, especially for those obese. And thus, dietary pattern change could be a feasible method in the prevention and management of pelvic floor disorder. And that's all. Thank you.
Thank you for this nice presentation. The paper is now open for discussion. Are there any questions from the auditorium? So if there are no questions, I would like to know a little bit more about dietary inflammatory index. Maybe you could say some words, how it is measured and when is it useful to determine this index, in what kind of setting, and how is it calculated? Can you say some words to this, please?
You want to know how the details about how to calculate the dietary inflammatory index, right?
Yes, and maybe you can say some words to the dietary inflammatory index. What is it exactly? When is it used? When it is useful to make this index?
When is used this index, right?
In what kind of clinical setting you would suggest to use it?
Sorry, can you, how to use it, right?
In what settings are you using this index? Is it a performed index? And maybe you could say some words to this index, if this is possible?
Sorry, I don't get it.
It's no problem. Then I think due to the time, thank you again. We will continue with the next presentation. Thank you very much. The next presentation.
Thank you.
The next presentation is from UK. It is a randomized controlled trial of the clinical and cost effectiveness of vaginal pessary self-management versus clinical-based care for pelvic organ prolapse. It is presented by Dr. Susanne Hagen. And beside, I would also like to mention that this paper was nominated for the best clinical abstract, so congratulations to you and your working group. Please go ahead.
And also to the scientific committee for letting us present the results of our research today. So TOPSY is a randomised control trial comparing two methods of vaginal pessary management for prolapse, self-management and clinic-based management. The research was funded by the NIHR in the UK, and I have no disclosures to make. So TOPSY aimed to determine the effectiveness and the cost effectiveness of women self-managing their pessary versus the more usual UK model of management in clinic. And we were interested in the impact that this had on the woman's quality of life. The trial was commissioned by the funder to answer this specific question. So they'd identified via women and via healthcare professionals in a research priority setting exercise that this was a very important question that women and healthcare professionals wanted to know the answer to. So TOPSY contained a randomised control trial in the blue section in the diagram here. And it also contained a qualitative process evaluation, which is a big part of the project, and you can see that on the sections on either side. And you can read about that in abstract number 18. So women in the trial were randomly allocated to one of two groups via a remote web-based system, and we minimised by centre by the woman's age and whether she was a new or an existing pessary user. The two groups in the trial then were self-management, where the woman had 30 minutes of face-to-face teaching on how to manage her pessary. There was written information also, and then there was a follow-up phone call after 2 weeks to make sure that the woman could remove her pessary and reinsert it. And also there was a telephone support number so that the woman could phone the local number if she needed any help. And the clinic-based women came to clinic at regular intervals to have their pessary checked and changed, and the frequency of that was determined by what was usual in the centre where they were receiving the care. So, for example, every three months or every 6 months. The women in the self-management group were given a supply of extra pessaries to use as required until they were seen at the long-term follow-up. Women in the trial were 18 years or older, and they used a pessary already for the management of prolapse. Any type of pessary was eligible apart from the shelf, the Gellhorn and the cube. And women had to have retained the pessary for at least 2 weeks in order to be eligible to come into the trial. We wanted to make sure that they had already established their pessary. So women were not eligible if they had poor manual dexterity or if they had a cognitive deficit, which meant they weren't able to self-manage their pessary, if they were pregnant, or if they required the self-management teaching to be in a non-English language. So we had a range of different outcome measures. The primary outcome, which was defined by the funder, was quality of life, condition-specific quality of life, which we measured using the PFIQ-7. And this was measured at 18 months after randomisation as the primary outcome. And higher scores on the PFIQ-7 mean that the woman has worse quality of life. We also measured pessary complications, pessary confidence, self-efficacy and adverse events. And those were amongst a range of other different secondary outcomes. We used the EQ5D to calculate the cost per quality adjusted life year for the woman. And the data were collected mainly by questionnaire at baseline, 6 and 12 months. And then all women had a vaginal examination to inspect the vaginal tissues at 18 months after randomisation. So this was a large trial that took place in 21 centres across Scotland and England. And women were recruited via the outpatient clinics in these centres. And this was taking place between May in 2018 and February 2020. So how did we get on? Well, over almost 2,700 women were assessed for eligibility for the trial, and we then randomised of these 340. 169 were in the self-management group and 171 in the clinic-based care. At 18 months, we had 83% and 91% respectively response rate to the PFIQ-7, which was our primary outcome. Overall then, in terms of results, the mean age of the participants was cost effective, and then using the modelling that we found that it was likely to remain cost effective for at least 5 years after the trial was completed. So to summarise then, there was no evidence from the trial that condition-specific quality of life as measured by the PFIQ-7 was any worse for women who self-managed compared to the women who were in the usual clinic-based model. But they had fewer complications and they were more confident in dealing with their pessary, and we found that self-management was more cost-effective. So thank you on behalf of the research team, and we want to acknowledge and thank the women who took part in the clinics and the clinical staff who took part and made this research possible. Thank you.
Thank you very much for this presentation, which really covers also a very, very important topic. The paper is now open for discussion.
So, Manuka from Austria, very nice presentation. Thank you very much for your work. Could you just explain why you excluded certain types of pessaries? What was the rationale, and is there any scientific background?
Yes, of course. Because the Gellhorn, for example, is not possible for women to self-manage because it has to be removed by a clinician, they wouldn't be eligible to be able to take part, to be randomised in the self-management arm. And then at the other extreme, so for example, the cube, because the cube has to be removed on a regular basis, women who use a cube have to be taught how to self-manage. So again, it wouldn't be ethical to randomise them.
Okay.
Anna Rosemillia. Melbourne. Thank you. It's a lovely demonstration of, I think, what most of us are doing in practice already, and I think in the UK possibly also. And I think probably historically this may have been promoted initially in Canada, a very long history of pessary self-management. So I suppose what it does is that it tells us what we already know. We know that women who are motivated, and I think you can see that by your very high or a low number of women who actually were randomised versus those who were actually offered the treatment or excluded for various reasons. And I think it's motivation that's going to be the main key. And I think it can also be extended to Gellhorn pessaries in those women who are motivated and dexterous enough. And we also anecdotally see the same thing, which is a much lower rate of adverse events because they can leave the pessary out themselves for a period of time. So it's a great study, and it's confirming what we do already.
Yeah.
But great to have
the data. I think
data.
I think it's giving the reassurance, I think, to clinicians that this is something that you can do without concern and it's cost effective.
Thank you.
Thank you.
I have also one question from the online platform. It's from Netherlands, with the question, were the women in the self-management group advised to leave the pessary out during the night or a regular base?
No, so they weren't given strict instructions about how to remove or when to use the pessary. That was very much left up to their own decision. And there was a real range of patterns of how women used self-management. So some women would perhaps take it out 3 times a week. Some women would maybe only take it out every 2 months. Some women took it out for the weekend. And so it was very much up to the women. We didn't give them definite rules on when and where to remove.
Okay, thank you. So if there are no questions, we will close the session and continue.
Thank you.
The next presentation is from Sweden, pelvic floor dysfunction 1 year after first childbirth in relation to perineal tear severity. Our presenter is Dr. Marlene Huber, and I also have to mention that this paper was nominated for Best in Category Prize, Female Sexual Dysfunction. I would like to congratulate you and your working group for this prize. Please start with your presentation.
Thank you for the presentation. I will present from northern Sweden, pelvic floor dysfunction 1 year after first childbirth in relation to perineal tear severity. I have nothing to disclose. This slide is in memory of my father, who was Austrian and who would be very happy to see me here today. So research has primarily been focused on complications after obstetric anal sphincter injury, and there's a lack of knowledge on complications following more moderate, spontaneous or iatrogenic injuries to the perineum. We also know from former research that women who have symptoms 1 year postpartum are prone to have it later on. The aim of this study was to evaluate self-reported symptoms of pelvic floor disorder dysfunction in primipares 1 to 2 years after their first birth and related to the degree of perineal tear. The cohort was part of a local interdisciplinary project on tears and pelvic floor dysfunction. It consisted of a web-based questionnaire, and it was distributed to 776 primipares and consisted of 15 questions. All women had been examined after birth to diagnose any perineal tear according to our standard routines, and we had ethics approval. 511 women responded. Some of them were excluded due to being pregnant again, and 12 incomplete questionnaires. The participants were divided into groups depending on the extent of the perineal injury, as well as a fourth group encompassing women who had given birth by cesarean section. This is the distribution of groups with a sphincter rate of 4.5% and a cesarean section rate of 12.7%. There were no difference in rates of perineal trauma between responders and non-responders, neither in the majority of background's characteristics, except from responders being slightly older. Epidural was more common in the non-responder group and vacuum extraction more common in responder group. There were neither any major statistical differences between groups regarding background characteristics, other than some of the well-known risk factors, where birth weight was significantly higher in the WACI group, active secondary state was longer in second degree and WACI group, and vacuum extraction was more common in the second degree group. To the results, 8% in total had symptoms of prolapse, 6% had to insert a finger in the vagina to assist emptying their bowels. Women with WACI had an elevated risk for symptoms of prolapse. Urinary incontinence was a very common symptom. Stress incontinence was reported by 31% and urge incontinence by 18%. Women with second-degree tears had an elevated risk for stress incontinence symptoms, and women with cesarean section had a lower risk. Women with WACI had an elevated risk for urge incontinence and incontinence that affected their lifestyle. Anal incontinence of any kind was reported by 14% of women, but leakage of stool was only present after vaginal delivery. 13% reported perineal or pelvic floor pain, and 21 of them so severe it prevented daily activity in the last period. Women with WACI had an elevated risk of having pain, and also an elevated risk that the injury affected their daily life, which was reported by 42% of the women in the WACI group. In regards of sexual function, there were 4 women who chose not to answer any questions about sexual function. Almost 10% had not resumed sexual relations at the point of the questionnaire. The feeling of being too tight was more common than the feeling of being too loose or open. The most common symptom in this cohort was dyspareunia, which was reported by 38% of sexually active women. To note that we are at least 1 year after delivery at this point. Women who had delivered by cesarean section reported dyspareunia in 31%, which was in line with those with intact perineum. Women with WACI had an elevated risk of dyspareunia, and it was reported by 63% of the women with WACI. Of course, as any study, we had some limitations. The measurement were of rather subtle symptoms of pelvic floor function ranging from 1 to 3 times a month to daily. There were no objective measurements of pelvic floor dysfunction, and as in any questionnaire, there's a possible recall bias. The sample size in the WACI group was rather small, which yielded wide confidence intervals. Nonetheless, we had non-selective inclusion of all grades of tears, as well as women who gave birth by cesarean section. And a functional impairment is an easy way, as you all know, to identify patients in need of further evaluation and possibly treatment. The earlier we identify an impairment, the earlier we can intervene. To conclude, in this cohort, OASI was an evident risk factor for pelvic floor dysfunction, and women who had OASI reported significant impact on daily life. Nonetheless, symptoms were common even in women with moderate perineal tears. Dyspareunia is a very common symptom after birth, and we find that there is a need for further research into this area, assessing pre-pregnancy function and long-term follow-up using some kind of validated tool. I also added this slide, but what can we as clinicians do? We can acknowledge the women and their symptoms. We can ask for symptoms, especially regarding sexual function. And we can avoid the everything looks fine approach to these women. There is possibly also a need for more follow-up physical therapy in the postpartum period, especially for women with complicated vaginal birth. Thank you.
Thank you for this interesting presentation. The paper is now open for discussion. Are there any questions from the auditorium? And I will check if there are online some questions. Yeah, there is one online question from France. Thanks for the presentation. How do you explain that, except for SUI, cesarean was not protective?
Oh, how would I explain that? I think
It's
that
a tricky question.
in addition to the way you give birth, of course, the pregnancy itself poses some risk to your pelvic floor. Also, some of the symptoms like anal incontinence are rather uncommon. Some women suffer from bowel dysfunction already before birth.
Mm-hmm. Do you have any idea, or could you summarize what kind of preventive strategies do you think were useful also to counsel patients to avoid all this perineal laceration, because you said postpartum physiotherapy, etc. But do you have an idea what preventive strategies before it comes to delivery would make sense? When it comes to delivery, of course, to lower the rate of OASI is relevant, but I think most centers already work a lot with that. In this material, the episiotomy rate was rather high. It was 20%, where the national average in Sweden is 10%. And I think that we were influenced by research saying that you should do an episiotomy when you have a vacuum. So maybe a bit restrictive to the episiotomies could help. It's one way. Yeah. So thank you. If there are no questions, we will close this paper and come to the next presentation. The next presentation is also from Sweden, Sexual Functional Pelvic Pain After Mid-Urethral Sling Surgery, presented by Dr. Anna Lundmark. Please start your presentation.
So good morning, and thank you for having me here. I'm here on behalf of my research colleagues in Stockholm, Karolinska Institutet, and Lund University. So I will talk about sexual function and pelvic pain 10 to 14 years after insertion of a mid-urethral sling. I have nothing to disclose. So what do we actually know about pain and sexual function long time after insertion of a mid-urethral sling? So pain and pelvic pain and sexual function, dyspareunia, is actually disputed, as we all know. after mid-urethral sling surgery. And we have not been able to show any definite benefit for any of the surgery techniques in the long term. What we know is that the retropubic sling might cause a higher risk for blood flow and innervation problems of the clitoris, and that the obturatoric sling might increase the risk of groin pain and postoperative pain. But we have not been able to find a definite benefit for any of the techniques. So we decided to look upon the situation for Swedish women who went through mid-urethral sling surgery during 2006 up to 2010. So first, I would like to introduce you to one of the many good medical registers that we have in Sweden, the Swedish National Quality Register of Gynosurgery, or in short, GNOP. So this is a register that was founded in 1997, and the coverage today is at least 85% or above 85%. And more than 60 hospitals report to the register. And concerning the sling surgeries, 2021, more than 3,000 surgeries were reported and registered. So it's a register that take information both from the patient before the surgery, 8 weeks after surgery, and 1 year after surgery. So they give a subjective, they give their subjective information, whereas the doctor register preoperative, intraoperative data and also postoperative data during the first year and any complications happening during the first year. So with the help of this register, we managed to reach the women that went through the surgery during the studied years. And we found almost 5,000 women being eligible for the study. We excluded later in the data the mini slings and the absorbable slings, and we had a response rate of 59%. So we focused on the retropubic and the obturatoric sling. So a very brief, informative slide about the population. The mean age was 64, and the mean time for follow-up was 11 years, and almost everybody was, in fact, postmenopausal, and almost half the group used any form of hormone replacement therapy, like either systemic or local. So back to the primary outcomes, which I might not have mentioned, but that was dyspareunia and pelvic pain after more than 10 years. So we posed the question, do you experience pain during intercourse? According to PISC-12. And we found no difference between the retropubic sling and the obturatoric sling. And concerning the pelvic pain, we used the UDI-6 question, the last question in that questionnaire, and we found that about 1/5 of the population actually reported suffering from this, but no difference between the two surgery techniques. And later, we also posed the question about the subjective result of the surgery. So we posed the question, what do you think about the surgery result at more than 10 years after? So the population had to answer whether they thought their condition was actually much better, down to much deteriorated. And we divided the population in two groups, the ones who reported being better or much better, and then the unchanged and worse group. And found out that actually 80% of the population reported being in a better or much better condition and having a much better or better result also after 10 to 14 years. And when we went back to the primary outcomes, dyspareunia and pelvic pain, we thought that it was a big difference between the ones reporting a better result, also after a long time. And when we fulfilled a multivariate logistic regression analysis, we found an odds ratio of over 3 for the group who reported worse or unchanged condition after surgery. And for pelvic pain, an odds ratio of 2 for the ones reporting an unchanged or worse condition or result after surgery. Okay, so in conclusion, we would like to state actually that there is no difference concerning sexual function, dyspareunia, and pelvic pain between the two main surgery techniques, and that the risk of dyspareunia and pelvic pain might or is associated with a worse self-reported result after Muse surgery. Yes, thank you very much. That's everything.
Thank you very much for this excellent presentation. The paper is now open for discussion. Are there any questions from the auditorium, please?
Thank you very much for a very interesting presentation. I think we should congratulate you on the number of women answering your questions regarding sexuality. 59% is very good. You didn't really find any difference between the different types of mid-urethral slings. But what do you think the rate of dyspareunia is in the general population in that age? Do you think it differs from what you found in the mid-urethral slings? I realize you perhaps have not studied that, but could you speculate?
Well, when I have studied it, and this big British study, I don't know if it was from 2017, they had a mean prevalence of dyspareunia at 7.5%. They studied like over 6,000 British women, but the age was 18 to 74 or 64, 74. So that was a widespread and a low percentage of dyspareunia. So I believe when you study the literature, it's between 7.5 up to 43% that actually suffer from dyspareunia. But the studied women are very often younger than my group or our group. So I think the next step for us would be, and we actually plan that, to study an age-matched control group of Swedish women to see, to get the percentage from them and then compare with the Muse women.
Anna Rosemalia, Melbourne, that was my exact question, was if you've got this registry, then you can, with ethical approval, ask the same questions to a group of women who've had hysterectomy or who've had another type of surgery, which may not be continence surgery, if you're interested in pain and dyspareunia comparisons, because, yeah.
Yeah, true, but still the cost of sending the questionnaires, that's the problem, I'd say, but definitely, but we also have other studies in Sweden that we can maybe use to collect just this specific question, and that's the plan.
I have also one question for you from the live chat. Did you get data on dyspareunia before the surgery?
No.
No.
Unfortunately not.
Yeah, thanks again. I'm always impressed how good is working your registers, what you presented. This is really perfect. I'd like to have this also in Austria. It's really great. Congratulations.
Thank you.
So we come to the next presentation. Next presentation, perceived health status after sub-urethral sling revision, about 290 women from the VIGIMESH registry, presented by Dr. Urogynaecology from France.
Here are the slides. So anyway, good morning everyone. I'm Urogynaecology, French resident in Poitiers. I've done this work with Professor Xavier Fritel and all the authors, and first of all, we would like to thank the committee for selecting our work and allowing present it today. I have no conflict of interest. We are going to talk about perceived health status after mid-urethral sling revision. Revision of the sling after complication is estimated at around 3 to 5%. And surgical treatment seems to be efficient, but unfortunately some women remain symptomatic. So the aim of our cross-sectional study was to evaluate health status after Mast revision. Our sample comes from the VIGIMESH registry. It is an observatory that collects data on complication after urinary incontinence surgery in 30 centers in France. And women who experienced at least grade 3 complication, according to Clavier and Endo, were included. We conduct a survey with the minimum European health module. There are 3 questions, and the first one was, how is your health in general? And this patient-reported outcome measure was our primary endpoint. The second question was about comorbidities, and the third one was the global activity limitation indicator. We chose those global health indicators so as to compare our operated women to the general French population. Think with the organism Eurostat, by using exact same questions, compiles yearly statistics about quality of life in Europe and in France. At the end of the questionnaire, women were allowed to express themselves freely, and we performed a qualitative textual analysis on it. Let's describe our population. Revision of sling took place between March 2017 and May 2021, and we sent the survey during summer 2021. We had 287 answered, which gave the response rate of 76%. Concerning indication for revision, it was essentially chronic pain, exposure, and urinary disorders. And as you can see, some indications were double or even triple. Concerning surgical procedure, major part was partial or total removal of the sling, and a quarter involved section or loosening of the sling. Let's see the main results. 49% of the operated women declared themselves in good health. It is less than the general population, 57% according to Eurostat, and this difference was statistically significant. 19% of the women declared themselves severely limited. It's more than the 13% of the French population. So we can say that our studied population had an inferior health status than the general French population. Finally, we performed a textual analysis on spontaneous declaration of the women who declared themselves severely limited. There were 52 of them. We were able to classify their spontaneous declaration into different themes, like pain, sexual issues, urinary disorder, despair, sense of failure, or conversely, impression of success. Some women only mentioned other health issues. And the strength of the word used showed us how much the impact can be for the women after a mid-urethral sling revision. We tried to find out if the mid-urethral slings could be involved in the severe limitation of the woman. And during the textual analysis, we noticed that majority of the women spontaneously expressed the origin of their severe limitation. So, for example, if a woman expressed pain or despair, we deduced that the mid-urethral sling complication and its revision was involved in her limitations in everyday life. And on the contrary, if she expressed impression of success or mentioned other health issues, we deduced that there was no limitation between the mid-urethral sling and her severe limitation. All in all, in our sample, 10% of women had severe limitation related to the mid-urethral sling. So, to conclude, we used a global PROM. It was good for us for comparing our population to the general French population. Half of women after mid-urethral sling revision were declared themselves in good or very good health. It is less than the French population. But even if our main limitation was not being aware of health status of the woman prior to surgery, we may suppose that mid-urethral sling revision has an impact on women's health. We also showed that 10% of the women we studied were severely limited in part because of the mid-urethral sling. And some women expressed strong sense of failure and strong sense of despair. So we think that all this information should be known by surgeons for their own practice and to inform women. Vielen Dank, and thank you for your attention.
Thank you for your presentation. The paper is now open for discussion, please. Are there any questions? So, if there are no questions, could you maybe go back and, or maybe you know it, without showing the slides, there was one slide where you showed the indication for mesh removal, or
May I have
it was
my slides again, please?
And there was one group, mesh exposure.
Yeah.
Yeah. Were these patients asymptomatic, or was this combined mesh exposure with pain, or do you also remove meshes just due to mesh exposure, but for example completely asymptomatic? Because there would be my question. This is also a group where you maybe start or try with local estrogen. Could you comment on this, please?
Yeah, I don't have my slide anymore, but I remember there is 57, I think, exposure that were not combined with pain or urinary disorders, and we get particularly to this patient, and we went back to the operative report to see if there is any other symptoms that could explain the removal of the sling. And on the 57th, I think there were 20 really asymptomatic, and the others had essentially least vaginal discharge, and sometimes it was hyspirenia. It was pain of the partner during.
So as I understand, so most of them had some kind of symptoms.
Yeah, but we try to separate more simply than it was more. The categories were too little to make very precise categories.
Thank you again. So we will come to our last presentation. It is an online presentation. Medical grade Manuka honey inhibits mast cell degranulation through downregulation of the protein kinase, potential intravesical agent in the management of interstitial cystitis or bladder pain syndrome. Presented by Dr. Omar Abdel Wahab from United Kingdom. Please could you play the slide?
Hello, good morning, everyone. Thank you so much for the presentation. And today I'm gonna speak about medical grade Manuka honey and how it actually inhibits mast cell degranulation through downregulation of protein kinase-B or AKT phosphorylation, potential intravesical agent in the management of interstitial cystitis, bladder pain syndrome. I have nothing to disclose, and Going through the background of interstitial cystitis. Interstitial cystitis is a disease which is characterized by a thin, leaky, defective bladder, urinary bladder urothelium that allows the constituents in urine, including potassium, to penetrate the tissue and desensitize the nociceptive sensory nerve endings, which is why patients cannot actually tolerate the urine, minimal amounts of urine in the bladders, and which causes the chronic syndrome of bladder pain, urgency, and frequency. The desensitized sensory nerve endings release neuropeptides such as substance P, which actually induces the tissue-resident muscles to be activated and degranulate, which release a wide combination of pro-inflammatory mediators, including tryptase and kinase, which in turn work on the the sensory nerve endings, desensitize them again, making a vicious cycle of muscle activation. In addition, muscles release other pro-inflammatory mediators, which actually feeds into the chronic inflammatory or chronic tissue inflammation we see in that disease. So our initial results using MediHoney, which is a medical grade Manuka honey of well-established antimicrobial properties, using LAT2 human mast cells in vitro, we were able to...
Recording in progress.
We were able so using human mast cells in vitro, the LAT2 mast cell line, we have seen that MediHoney was able to inhibit the degranulation induced by the neuropeptide substance P. So as we can see in that, sorry, yes. So as we can hear in that graph, substance P induced 40% degranulation, which was inhibited in a dose-dependent fashion by pre-incubation with MediHoney. So that has given us an indication that MediHoney has strong antimicrobial properties. Then we went to investigate actually what MediHoney does inside these LAT2 cells that results in this anti-inflammatory effect. So we have studied the intracellular signaling events inside the LAT2 cells. So we have studied the intracellular signaling events inside the LAT2 cells, accompanying the substance P-induced activation, both on 1 minute and 10-minute incubation. And we have found that substance P induced a significant increase in the phosphorylated levels of AKT, as we can see from the blue arrows here. So that is a spontaneous, which increases on the substance P, and it drops significantly with MediHoney pre-incubation at 4% concentration, which is actually the concentration that we have used here, because there was no significant difference between 6 and 4% in its mast cell stabilizing effect. So going back to our phosphorylation study, we have seen also that that MediHoney pre-incubation inhibited AKT phosphorylation in a certain limit, which was statistically significant. It also inhibited WNK1, STAT3, and RSK1, 2, and 3 phosphorylation using a proteome profiler from R&D systems. So actually going through the literature, we found that ERK phosphorylation and AKT phosphorylation are well documented and well established to be responsible for mast cell activation and degranulation, both in vitro and in also explant in cell lines like LAT2, and also in explanted cord blood-derived or peripheral blood-derived mast cells. We've also found that WNK1 as well is responsible for membrane expression of glucose transfer proteins which uptake glucose into the inside of the cells, while STAT3 is essential for oxidative phosphorylation in mitochondria. So both together are responsible for energy production. So that and the inhibition of the activation of these kinases could potentially inhibit the energy production and accordingly mast cell degranulation. At the same time, medi-honey at all concentrations did not induce any cytotoxicity despite inhibiting glucose, potentially inhibiting or reducing glucose uptake. Then from these results, we conclude that medi-honey, or the aqueous solutions of Manuka honey, anyway, aqueous preparation, if introduced intravesically into the bladders via catheter, this can potentially inhibit or suppress the chronic inflammatory or chronic tissue inflammation seen in ICVPS. At the same time, medi-honey, due to its superior antimicrobial properties, it can reduce, if used in combination with other intravesical agents or other conventional intravesical agents, it can reduce the possibility of the urinary tract infections that can happen on regular catheterization. So, thank you so much.
Thank you so much for your presentation. So this paper is also for discussion now open. So if there are no questions, thank you for this presentation. It's quite hard for me to ask you something regarding these findings, but what I would like to know, or I'm interested in, is it possible, or are you planning at your institution maybe someday to use this Manuka honey in a clinical setting to treat patients in future, or is this possible? Is this an idea? Could you comment on that?
So actually, it's not only medi-honey, but we are working on other components of or other isolated fractions of honey, of Manuka honey, which are actually as effective as the honey in terms of anti-inflammatory properties, but not as superior as antimicrobial properties, because you're actually removing other agents out present originally in that honey out of the equation. Knowing that honey is actually that medi-honey is just a medical grade gamma irradiated whole Manuka honey. We are now, returning to your question, we are now launching a study where we have started with a very preliminary work with PPI groups who reported dramatic improvement in their clinical outcomes on the intravesical instillation of honey, especially urinary tract infection patients as well. So we are planning to, we're going to start. I think very soon we're going to launch a study where we are going to introduce these medi-honey preparations intravesically, and we're going to notice that we're going to follow up their clinical outcomes and also their urinary cytokine and pro-inflammatory mediator profile, and try to match those and see how patients are doing, and to compare this with standard of care medications.
Thank you.
And hopefully we see something. Thank you.
Thank you very much. So as this was our last presentation, I would like to thank all presenters for the excellent presentation. I would like to thank you for your attendance, and we will close this session now. Thank you.
Thank you.